and then we shall begin. So I'll hand over to Mark to begin with.
Thanks very much. So I'll make a start just while we're going to presenter mode. So we're here to talk about the LOLIPOP trial, specifically your site initiation visit. So we've obviously had a previous feasibility call, haven't we? So hopefully this is, has become fairly familiar to you. But just to quickly recap, we're looking at lidocaine infusion to hopefully prevent long-term post-operative pain after breast cancer surgery. It's a trial that's been originated by the Australia-New Zealand College of Anaesthetists Clinical Trial Network, a very experienced trial network. But they've been going with the trial for a year or so before we joined in, got some NIHR funding, and the trial's sponsored in the UK by my employer Southampton, and supported by the Bristol's Trial Centre as our clinical trials unit. So the next slide just gives us a bit of introduction to the overall trial aim. Patient group of adults undergoing primary breast cancer surgery, intervention of systemic lidocaine, which can be either given to day case patients just during the operation into recovery, or for overnight patients can be given on the ward as a subcutaneous infusion, although not many UK sites are aiming to go for that. The comparator being a placebo, also infused, so fully blinded to all, and the outcome being 1 year time point for chronic post-surgical pain. Probably just worth pausing at that stage, obviously, just before we go into the inclusions, just to discuss overnight versus day case. As a site, you've probably been thinking about whether you want to sort of tackle the overnight ones with subcutaneous infusions on the ward, or stick to primarily day case, particularly if they're your primary workload. Have you had some discussions about that and come to a conclusion about which patients you will aim for?
Yes, hi Mark. I think we'll only do day case ones. I think probably even to that, if for whatever reason someone stayed as an inpatient for whatever reason, I suspect I'd be interested in what, even if they stayed over for unrelated reasons, I don't think we'd continue the infusion beyond recovery.
No. So basically the trial track that they're on should really be based on what the preoperative plan was.
Okay.
So if a planned day case patient ends up staying for whatever reason, the trial does not try to sort of convert them to an overnight stay type patient. So yeah, if you just target the day cases, yeah, if they do happen to stay for whatever reason, then the infusion stops just as if they've been planning to go home. So fine, that simplifies matters, and you're in good company with pretty much all of our other UK sites, Belfast in fact, who are going to be doing the overnight infusions, but all others are just targeting day cases. Okay, fine. So next slide just goes through inclusions, exclusions. Inclusions are surgically very broad, which helps. So adult patients, it's got to be the primary breast cancer. So recurrences are out, but it can be either sort of breast conserving operations or anything up to mastectomy, with or without axillary elements, and it can be unilateral or bilateral. So really very broad. Simple sort of implants or expanders that are being put in at the same time are fine, but we would exclude patients who have got a very definite plan for a major autologous graft procedure in the sort of the months after the surgery. Exclusions are primarily to avoid the sort of confounding factors. So if there's pre-existing pain, we don't include the patients. If this is repeat surgery, again, we exclude the patients. And then other things, we obviously keep it to a slightly fitter patient profile, so ASA score 3 or lower, and a long list of sort of various ECG and electrolyte abnormalities that would preclude them from basically safely dealing with the lidocaine that we're going to infuse. We want to keep the trial as safe as possible. None of this stuff should need any additional screening tests that you wouldn't be doing for your normal preoperative workup anyway. So really it's just the exclusions are based on things you've discovered during their pre-assessment and what you know about the patient anyway. Okay, any questions, concerns about the patient group and the inclusions? Yes, 2 hands up. We've got Donna first.
Maybe it's the same question. Frozen shoulder, do they get excluded? Because it seems to be a very common
Okay, so if they've got pre-existing frozen shoulder.
On the same side.
I would say if it is a painful frozen shoulder and it is on the same side, probably I would exclude them. We can actually just we'll perhaps just get back to you on that one, because I think we talk about pain being at the site of surgery as being the exclusion, but I'm not sure if it's a slightly more generalized shoulder thing. I think if it's unrelated to the cancer, that it's possible if we get them in. We'll check with the Australasian team about that one. That's interesting.
Okay, thank you.
And another hand up there from Louise.
Yeah, my question was just about a therapeutic mammoplasty. So it's a little bit more than just a wide local excision, but it is breast conservation. Are they allowed?
Yes, I believe so. Yeah. Yeah.
Okay, great.
Okay, great stuff. So we'll move on to the next slide. So this just goes through the sort of the trial process, really. Splits down to in the middle, but you'll only just be concentrating on the left-hand intraoperative part. So the green bits are the sort of the finding your patients and consenting them. Protocol's nicely broadly written so that you could do your first approach in a number of ways and by a number of team members. For example, at Southampton, the surgeons just have a single listing clinic where they'll see the patients. They actually simply signpost to the trial, and that we've got some literature in the waiting rooms of the clinic. So they just mention it really just in broad principle. But then our research nurses are screening the operating lists on our electronic scheduling system, and those lists get populated a week, sometimes 2 weeks in advance. So they're on the lookout for example, patients for next week. They'll be looking at this week, looking at the eligibility and so on. They're then contacting the patients and sending out information. You can do a lot of the consent discussion by telephone if the patient's not going to have a physical presence in the hospital. Although today, for example, they're popping down to the pre-assessment clinic because there's a patient who knows coming in for pre-assessment today. So it accommodates a variety of phone or face-to-face consultations. The key thing is that all the thinking and the Q&As really need to be done before the day of surgery. So you can physically sign the consent form on the day of surgery, but really it's sort of confirming that they've had the discussions and plenty of time to think about it with all the information. Shouldn't really be presenting any new information on the day of surgery. Once written consent has been obtained, randomization should happen on the day of surgery, and that all comes through the central trial database. That allows the dispensing of the trial vial, which gets double checked, gets drawn up by the research team, put onto a special pump that we'll provide you with, and cross-checked with the anaesthetist. And then that gets started after the patient is asleep and the airway's secure and everything's stable, but before knife to skin. And then the bolus that comes from the pump then automatically rolls onto a set mils per hour infusion, which is based on the patient's lean body weight, as is the bolus. Lean body weight having been calculated from the trial database. And then the infusion continues through into recovery. So it carries on recovery, and we recommend ECG monitoring recovery while the infusion is running. The patient gets asked some of the questions from the LIST tool, which is the specific trial thing, which is trying to detect with quite high sensitivity any early signs of local anesthetic toxicity, and that's administered, as in the questionnaire is administered as soon as the patient can sort of converse after they've woken up, and then again when the patient's ready to leave recovery. And they should leave recovery when they're clinically ready. So if they're only needing 20 minutes, 30 minutes in recovery, and then they're ready to go, that's when you stop the infusion. And the maximum time period should only be an hour if they stay in recovery for that bit longer. Then once the patient's gone home, obviously, I mean, there's been data collection, a little bit of baseline data, quality of life stuff and so on, pre-op. There's some stuff from intra-op, other analgesic uses and that sort of thing. And then there's some post-op data collection as well. After the patient's gone home, there are 2 time points that need a bit of a medical notes review, but you shouldn't have to chase the patients for the patient-reported stuff. So in the UK, we are getting that done using an automated system. The patients get a text alert asking them to log into the online database, and they fill in their own patient-reported outcomes, including at the 1-year point. If we cannot get hold of them and they've had reminders from the system, then we might ask you to chase them up. But it means that a lot of the data collection is going to be quite light touch from your point of view. Okay, any questions on that so far, or the sort of anything from the trial overview training module? Joan.
The baseline, the pre-op questionnaire. So I know that I think there is an EQ5D and a hack as well in the pre-op questionnaire. Is that correct?
Yeah.
So would that be filled in by the patient after written consent, or can that be filled in after verbal consent?
Ooh.
Just
What scenario are you thinking of? I think we normally do it after written consent because it's quite routine for us at Southampton, certainly to get the form filled on the morning of surgery, just because they perhaps haven't been in the hospital for that. So we get them to do that and then roll on straight away to the EQ5D and so on afterwards.
Okay, that's fine. That's fine. Thank you.
The other thing to say about the consent form is if you've been having the discussion with the patient over the phone in the time leading up to the operation, you can post out the consent form if you'd like to just make things a bit quicker on the morning of surgery. So you can post it out to them and they can pre-sign it when they come in, which sometimes helps.
Yeah, that's
save
what I'm
time
thinking.
on the day of surgery.
There would be time. Yeah. Okay. Thank you.
Louise M.
I just wondered, out of interest, how long it takes from seeing them this morning of surgery to consent them to being randomised to get them into theatre. Just trying to think about our list timings because we get heavily monitored on our efficiencies.
Yeah, no, sure. I'm just trying to remember if we've had many that are first on the list. It does need a little bit of time. I mean, it kind of depends a little bit on the logistics of, for example, where you're going to store the study drug and so on. I would say it's doable to have a patient that's first on the list, but if you are able to control the list order a little bit, it might be a bit easier and give the research team a little bit of time to try and get these patients sort of second, third on the list and so on. As I say, I think it can be done first on the list without too much delay. So it's just a bit of an early start for the research team, and they just have to be there really ready to pounce, with their consent forms and so on. So yeah. And Andrew.
Yeah, thanks. Just to say, I think when we've done some of the things before, we have been able to do it on the first patient, but it has been an early start for the research team to sort of meet them, consent them sort of at 7:30, because the patients come in at 7:30. And it's involved a bit of liaising with the admission team, so that the research team can get in and do their bit, and then everyone takes over after that with the usual care.
Yeah, no, John and I were just talking that it might be best if it was the second patient on the list to help avoid a delay, and that if maybe it was only one patient per list as well, rather than two. But we can talk about that locally.
Yeah.
Angela, do you have a question?
I was just going to actually bring Andy or Louise into this one about pharmacy availability for getting the drug in the morning as well, but we can talk about that outside of this as well, just for logistics and lists and things like that.
Might be useful since you're all here to talk about that now. I mean, if you've got everyone that needs to be, because obviously we can compare notes about how different places do it. I'm not sure what thoughts you've had so far about where you're going to store the IMP. I'd say probably a majority of our recruiting sites have their trial pharmacy in a receipt-only mode. So they would receive the IMP when the shipment gets there, check it and so on. But then actually the storage is outside a trial pharmacy and is in a suitable facility closer to the research team. And obviously that needs to be a locked cupboard. We advise temperature monitoring, although it does not need temperature control. But what that means is that you don't need to wait for trial pharmacy to open in the morning, and obviously the additional time that they will need to sort of dispense. So that model is good. It works well. I'm not sure if you'd thought about doing that or if you're keen to keep the IMP within trial pharmacy.
I think we were thinking of keeping it in pharmacy, but it's certainly something we can look into.
Do you have, Angela, do you have any suitable cupboards, storage areas?
Not that I'm aware of. The one that we previously run that was similar to this study, I think we did, like Andy was saying, get the drug on the morning of the procedure. Yeah, I mean, we can have a look at that, but maybe like Louise was saying about perhaps having on second on the list might be our best option just for all logistics. But yeah, perhaps we could have a little think about that. I don't know of anywhere. Andy, do you know of anywhere in theatres, either of the Andys? Sorry, there's.
I don't know regarding the research. I mean, I know we have lots of drug cupboards, locked drug cupboards, but I don't know specifically. I'd have to find out a bit more about that.
If it was stored in theatre, what sort of temperature monitoring requirements would you need?
So we just basically we leave temperature monitoring up to you and your local policies. We just need to you need to be able to tell us basically if there's been a breach. So storage is below 25 degrees, and if it was to go above that, you need to report it to us. So yeah, we're quite flexible in how you do that. But yeah, you just need to be able to report if it does go above 25. If it does, it is highly unlikely that the drug will need to be destructed or not be unusable, because we've got sort of stability data up to 40 degrees. But unfortunately, because the protocol stipulates storage below 25, we do have to monitor that.
I'm not sure what sort of temperature monitoring they've got in theatre.
No, I guess we could do. I mean, it's worked before keeping it in pharmacy. I guess if there's a viable option that's quite easy, it'd be good if we could keep it in theatre. But I think it could work in pharmacy because it's not that far. But what time would pharmacy be able to start?
So we start at 8:45. And it's something we could prepare quite quickly. I think. I don't think it would take us long to get the drug ready. Once the patient's been randomised, would we receive an email with a dispensing sheet on? Does anyone know?
I can do that, Andy. I can email you.
Okay.
But I guess if the patient was first on the list, that would be about sort of 8 o'clock.
So perhaps second, maybe the better option
Yeah.
if we can do it. I suppose the first one, if we can aim for it to be the second on the list and do a bit of troubleshooting and see how that goes. And yeah.
What sort of time would you expect that to be?
Depends what the first case is.
Okay.
But I think the patient would come in at 8, so I think 8:45 probably would be the time thing that the consent would be done by, and
yeah,
balls rolling, if you see what I mean.
What I would say is it sounds like perhaps make a start with storing pharmacy and target, or if you can switch around the order to have the patient second, that's great. You might, however, come to a point when there's a clinical reason where that patient just can't be moved and they've got to be first, and then you essentially start losing patients. All I would say is when we looked at our numbers, we thought, God, we have so many patients, but you just realize you need everything lining up, not a week when your staff are off, clinicians that are happy with it, patients that said yes, all these things sort of need to line up. And just what we found is if there's just one thing that doesn't line up with everything else, suddenly you just start to lose that small number of patients on a regular basis, and it just hurts your recruitment rates a little bit. So I guess if you can facilitate all patients to be possible as much as possible, then that really just helps kind of keep that consistency of recruitment. But by all means, get going with your existing setup, test ride it for a little while, but just perhaps have at the back of your mind what we're going to do with plan B if we find the logistics aren't working, or we're losing patients because they can't be moved from first to second, for example.
Yeah.
Okay.
Sounds good.
Fine. Anything else for those first few slides, or I think I'm now handing on to Chloe, I think.
Yep. Thanks, Mark.
Great. Over to you.
Thank you. So yeah, just a bit of a trial update for you. Oh, sorry, my notes are blocked. So the trial as a whole, so there are sites open in Australia, New Zealand, Hong Kong and the UK. So we've got 19 active sites open in Australia, and they've recruited 538 participants, 2 open in New Zealand, and they've recruited 68 participants, 3 in Hong Kong and 301 participants randomised. And then here in the UK, we've got 6 sites open at the moment and 34 randomised. So now we're just going to stop and have a bit of a sort of discussion and a bit of an interactive session. Yeah, as I mentioned at the start, it's not planned to catch you out in any way. It's just to get you involved so you're not sat listening to us for the whole hour and a half or however long we take. So just a bit about screening, consenting and randomising. This is, again, presuming you've watched the training videos. So yeah, if you do have any questions, please feel free to ask. But could you just sort of just like, so someone outline to us sort of who's going to identify patients and sort of how and when they're going to be approached for the trial and who will be doing that? I can't see anyone either. Well, I can see about 2 people, so feel free to just shout out.
I think from looking through the videos, the plan was that Donna and I bring the trial up with the patients in their results clinic as part of their surgical plan, give them the patient information leaflet to take away. And then Joan was going to follow up with a telephone call to gauge interest, and then we would plan from there.
Great, sounds good. So then leading on from that, if a patient was to consent, could you run through sort of how you envisage things working on the day of surgery and sort of the randomization process? I think we've touched on it a little bit with the pharmacy storage of IMP, but yeah, have you thought about the logistics for the day of surgery? Because obviously there's quite a lot to get done on that day.
I'm really conscious that I'm not sure Joan's able to talk where she is, so I'll run through it, but Joan, feel free to interrupt me. So we imagine what will happen from a research nurse team point of view is that one of the research nurses will meet the patient up on the admissions unit, speak to the patient about the study. The patient would have already been spoken to on the phone, had our questions answered. They'd have the opportunity to ask more questions. The consent would be signed. We've agreed that that would be done by the research nurses with the consultant having conversations with the patient previously, which would be documented in the patient's notes. The research nurse would then go on to randomise the patient and give out the patient questionnaires. Once the patient's been randomised, the research nurse would generate the prescription, which would be sent to pharmacy, and then the research nurse would go down and collect the drug from pharmacy to bring it up ready for the patient for when they go into theatre. They would also be drawing up the medication, I believe, and also supporting the anaesthetist with the setting up of the administration and the forms that need to be completed during the administering of it during the procedure.
Great.
Or something else I was going to think of something and I've forgotten what I was going to say now. Sorry, it'll come to me in a minute.
Yeah, that's all right. No, that was a very detailed run through. Sounds like you've got it all planned out ready. So then, yeah, next question. Have you thought about the potential of having 2 Lollipop participants on the same theatre list? I will say maybe not something to begin with, you know, while you're familiarising yourself with the trial. It might be worth, you know, sticking to just the one, but sort of once you're comfortable with the trial, have you thought about if it might work having 2 on the same list and how you would manage that?
Do you want me to?
Sorry, you go, Angie.
I was just going to say, from a research nurse point of view, we do have both Joan and James who are going to be working on this study. So we do have 2 research nurses available to do that. From our perspective, it would be doable. I'll let you talk about it more though, Andy.
I was just going to say, I haven't actively sort of thought about it, but I can't think of any barriers to it, because they could. Sometimes we have 2 different lists going. If it was Donna and Louise, do you ever work on the same day? So I guess they might be on. You don't work on the same day. So consecutive patients with research nurse support, it could well be feasible. I can't see a reason not to.
So yeah, sounds great. Just something from sort of a logistics side of it. You'll only have 1 pump. So yeah, so just something to consider with that is, again, if you do have control over your list, perhaps having a non-Lollipop patient between 2 patients allows that pump to become free. And then also, Mark, might need you to jump in on this, but I think once the patient goes into recovery, and they're on that mils per hour rate, you can switch to using just a standard pump. Is that right, Mark? For that mils
Yeah,
per
that's
hour?
right.
Yep.
They've been doing it in Australasia a little bit. You know, the beauty of using the Alaris, and they're all programmed, is that you don't have to mess around with setting the bolus right and then setting the mils per hour rate around a busy time of the anaesthetic, which is great. It's just a press green and it goes. But yeah, as Chloe says, by the time they're at the end of the surgery, it's literally just operating as a standard mils per hour pump with a rate that won't change. So you can actually just briefly interrupt the infusion, put the syringe in a normal infusion pump, and let them go into recovery with that one, and then reset the Alaris ready for the next patient. That's acceptable in the eyes of the Australasian team, and seems very pragmatic if you end up with one after the other.
Okay. So I guess it would be possible, but yeah, swapping pumps, I guess, wouldn't be ideal. I think we'd probably try and put somewhere in between if that was the case.
Yeah, exactly. Yeah, but yeah, it's certainly allowed and has been done. But yeah, something to think about for the future. Obviously, you get yourselves well bedded in first before you think about that, I guess.
Yeah.
Great, thank you all. And then next is just about training, and have all sort of anaesthetists, surgeons, recovery nurses, are they all aware of the trial and been provided with necessary training materials? So from the call today, I can see we've got good representation from departments, so I assume the answer to that is yes. Don't know if you've spoken to your recovery nurses yet, but we do have sort of a slide set you can use to go through that with them. So it's one that Mark uses at Southampton, and we've just sort of taken out the Southampton specific details for you to then just insert the details that are relevant to your site. And we've also got a similar slide set for anaesthetists. So anaesthetists who will sort of purely be the attending anaesthetist on a Lollipop participant, they're not going to be sort of actively involved in the trial. They don't have to go on the delegation log, but they will have to do just a small bit of training. So again, we have a slide set for that we can provide to you, and you can just localize it a little bit, and then they'll just have to fill in a sort of brief training log, so we know they've done that. So yeah, have you got any questions, or have you sort of, you know, done that sort of brief training with anaesthetists and recovery nurses?
We haven't done the training yet, so no. I think Donna and Louise are going to be the only surgeons, so they're on board. All the anaesthetists know about it, are on board with the project, and the same with recovery, in terms of, but they haven't had the specific training videos yet in recovery or the anaesthetists. But they know, well, particularly the anaesthetists know they will have to do it, and they're very happy to. I just need to, identify the anaesthetist is going to be doing it, and they'll do that. So if, were those videos on the training videos that we got sent for the
Yes.
pre-SMB?
So they are, but actually I think we've made it a little bit easier sort of since the start of the trial. So I'll send, after the SIV, I'll send you the slide sets, and basically the slide set covers what they need to know, and also for the anaesthetists, the videos they need to watch are embedded within, so they don't have to worry about sort of logging in onto the system and I guess getting freaked out by all the videos. It makes it a lot simpler. So I'll ping them over to you after the SIV, and hopefully that'll make things easier for you and for them.
That'd be good. And in terms of the recovery nurse, I guess I hadn't thought about them having specific training other than, essentially just sort of carrying out the assessments. So do they need to be on the delegation log as well, the recovery nurses, or are they a bit like the anaesthetists that they're just?
No, so they don't need to be on that. And again, I think the slide set for them is more just making them aware of the trial and sort of what to do if, for example, lidocaine toxicity, that they're suspecting that is sort of, just brief outline of the trial and sort of logistics from a safety point of view. Again, they are quite a brief slide set as well.
Okay, great.
But yeah, they don't need to be on the delegation log.
I think what we did previously, sorry interrupting someone. What we did previously was we did a bit of training. So the research nurses went up and did some training with the recovery nurses. And then as each patient came through to recovery, there'd be like a slight handover recap, so that actually the research nurse handed that over for observations and toxicities and things like that. So I guess that's kind of our plan, if you're happy with that. Do they need to all have signed the training log, the recovery nurses?
No.
No, perfect.
No.
Thank
And I
you.
think we're going to concentrate on doing it in specific lists in day surgery. So it's not going to be in the main hospital, main theatre recovery. It'll be in day surgery. So that's a much smaller team anyway.
Great.
Yeah, I think you'll probably find, you know, in the early days with the initial batch of patients, you'll probably want the research team to be there in recovery, sort of do a bit of hand holding and guiding them through list while they get familiar with it. If it's a small team and you get a decent number of patients coming through, you hopefully will get to a stage where you don't feel you need to be there actually, and they're all confident scoring the list and looking out for anything that is a concern as long as you're available. In terms of the anaesthetists, Andrew, I sort of had grand plans to sort of do big teams meetings and have everyone dial in, and provided a load of free dates, and basically nobody dialed in because we were just so busy. I mean, it's so straightforward. I ended up just literally circulating the slides by email and just saying, look, if you ever do a breast list, please just check in with these slide sets. But to be totally brutal, the thing to do is basically just once you've got a definite patient, identify your anaesthetist. That will probably be the nudge they need to actually look at the slide set, and then it's at least fresh in their mind. And I just sort of would jump on the email trail from our research nurses directly to the anaesthetist and say, oh, hello, you know, you've got a patient coming out, just do the slide set for us, and you know, if you've got any questions, just give me a shout. And then for the anaesthetists, we do ask that they're signing themselves off as trained. They can either do that. There's an online form they can use, or if you'd rather just have a paper one because it's simpler, then you can do that. So our research nurse, they'll take the paper copy of the training log to the theatre on the morning of, and just get the anaesthetist to sign it, you know, the first time they do a patient, just to confirm that they've been through those slides and they're happy with everything. But I mean, it's so straightforward. I don't feel it's a big deal. It's mostly just sort of things about, you know, here are the toxicity signs to look out for, and here's what the trial would say at the times to stop it, and what to do if the pump conks out and all that sort of stuff. But it's all in it's in the slide set, and we've got a little cheat sheet as well that they can have with them on the day of surgery.
Yeah, great. Sounds good. Perfect. Thanks.
Thank you. And then, yeah, final question on this slide is, have you had a chance to use the staging database, which is the test database, and do you have any questions at all on the database?
I've not used it yet. No.
I've not used it yet. I don't know whether Joan and James have managed to get onto it, but no, we've not used that yet.
That's okay. Yeah, if you do, go on, Mark.
Go on, Chloe, sorry.
I was just going to say, if once you've sort of had a play around, and if you do have any questions, just, you know, drop us an email or give us a call and we can help out. Have you managed to activate your accounts? Because the links do expire. So if you haven't, we might need to get them resent to you.
I've logged in and
I
activated mine.
have activated it, but I haven't really played with it.
Yeah, I've watched most of the videos.
Great. Thank you.
Yeah, and just to say, once you've had a familiarization with the test version, please, and you go live, please remove any web links you have or favorites or anything on your browser that takes you to the test site, because it's possible in a bit of a rush in the morning to log back in there and to think you're using the real system. Ask me how I know.
Thank you. So any other questions about screening, consenting and randomization? Nope. Going to hand back to Mark then for a couple of slides.
Good stuff. So a sort of real central part of the running on the day is this dispensing sheet that the database churns out. Once you've told the database all about your patient, including their weight and height, it will do a nice calculation for you to give you their estimated lean body weight, and that's the key number for the program with the pump, and it will tell you what it's expecting the pump will want to give for the bolus and for the infusion, which is all very nice. So that serves as a cross-check. So once you program those numbers into the Alaris, you can then do a two-person cross-check between the anaesthetist and the research team member to make sure those numbers all tally. The other nice thing about the dispensing sheet that you can see in blue is that if there is interest in using other local anesthetics, either for wound infiltration or for specific regional blocks, it'll give you the maximum permitted dose of those local anesthetics, which is important because those amounts are lower than you would normally be able to use as a maximum. So to give a bit of a safety ceiling, those are less than they would be normally. So please do follow those ones if you want to use alternative local anesthetics. So that's the blue bit there. The red bit is essentially who signs what. So essentially you've got somebody who's getting the vial from the cupboard and that should be cross-checked with one other person. And then the other check later on is once the vial has been drawn up into a syringe and programmed into the pump, that then is cross-checked between the research team member and the anaesthetist. So those people should cross-check at the same time. Just the yellow box there highlights that we think it's something to do with the rounding of how the database does the calculation and how the Alaris does the calculation, but occasionally you can see a basically insignificant discrepancy in terms of the bolus rate, and there might be a 0.1 mil per hour difference, and you can do the maths about that over the course of a 5-minute bolus and realize it's completely insignificant, but just a small error. But we know we've got very eagle-eyed research team members at many of our sites, and it sometimes just raises a, oh, what should we do here? Please just accept it. If it's that 0.1 mil an hour difference between the two, that is acceptable, and clinically and real life completely insignificant, just a small calculation difference. Okay, any questions on that? And I don't know if it's useful just to talk briefly about what the attitude's been in terms of using other locals at your site. We had some conversations with our place because we've got a couple of real keen blockers who were a little bit like, oh gosh, use less than my usual full dose. I don't know how I feel about that. I have to say I've managed to get stuck in and I seem to be quite happy using it now. But what are things like at your place in terms of using blocks and infiltration?
I think for these, it tends to be surgical infiltration. I think only sort of blocks for implants and the like. So that blue box would be really useful. I'm going to sort of check with Donna and Louise about that. That's because I was thinking we'd just have to sort of recalculate how much everyone was getting, but generally it's surgical infiltration what we tend to do. Yeah,
it's quite topical, obviously, with that coroner's case and everyone knowing exactly how much local they're allowed and that sort of thing. But so it's quite nice that that's built in. In fact, the Aussie team have even got I think we've got access to it, Chloe, haven't we? They've got a little Excel spreadsheet where, you know, if you've got like a laptop with you or something, you can use it, and essentially it makes it even easier because it's not just giving it in milligrams. They can actually sort of say, right, if you've got blah milligrams, you know, choose which concentration of local you're using, and it will tell you how many mils and that sort of thing. So if you want access to that, we can provide that as well.
Okay. Thanks.
Okay, great. Let's move on. So the Alaris pump, so obviously we provide one of the new ones, the Alaris Nexus. Do you use Alaris in your site for TIVA anyway?
We do, yeah.
Yeah. And have you got PKs or have you got Nexus now?
Oh, that's a question I should know.
No problem. Anyway,
I think there might be Nexus now. There definitely were PKs.
Yeah. I mean, they're almost indistinguishable, to be honest. So yeah. Obviously, the pump we provide will have been repurposed. So when you switch it on, the only two ways you can use it are either in mils per hour or LOLIPOP protocol. It won't give you any of the normal TIVA options, obviously for safety's sake. It'll have a load of stickers on it saying that it's just for use in the trial, and a little reminder sticker that you should be programming in lean body weight, not actual body weight. The way you program it is essentially turn it on, choose LOLIPOP, put in the weight, and literally from there you can just pause. This will be the research nurse doing this. Load up the syringe with the drug in and just pause there, because that will then display those numbers that you need to cross-check against the dispensing sheet. It won't alarm, it'll just sit happily with those numbers being displayed. And then you press OK to confirm it, and you're ready to go. It works with pretty much any 50 ml syringe you might use. We use BB Plastipacks. I think the first time you put your chosen syringe in, you obviously just have to scroll through the options to select the correct one, and then I think it remembers that and defaults to it for future uses. You might have seen in some of the trial literature some stuff around Terumos. That's actually only relevant if you were going to be doing a post-op infusion, but you can just use whatever standard 50 mils you use already. And in terms of sort of delivering it, the main thing is just that, you know, it's got some sort of giving set with a one-way valve. We've had various discussions with our place. Some people have chosen to put in a new cannula just for the infusion. Other people are happy to sort of put it on Y connectors, depending on whether they're using 2 lots of TIVA or 3 lots of TIVA or whatever. You come to a solution, but yeah, you can put it through its own cannula if you want, or if you'd rather not, then, you know, a bunch of Y connectors. Yeah. Any questions about the pumps?
That was great, thanks.
Yeah. And just to say as well that your medical engineer will just need to receive them and do electrical safety check, and then they actually come back to us for maintenance, but they've got a 3-year maintenance cycle. So hopefully you'll be able to keep it at your site uninterrupted for 3 years, and then we'll be done with recruitment. But if there are any problems, we'll swap you in a replacement pump temporarily and that sort of thing. So okay.
Thanks, Mark. Back to me. So this table you can find in the study protocol, and we'll also provide you with a printed copy. So Annie, our administrator, I think, will be posting you sort of a starter pack of supplies this week or next week. So a laminated copy of this will be in there, and this should sort of remain close by to the participant at all times whilst the infusion is running. So it basically just gives an outline of sort of when the infusion should be stopped in sort of different areas. So you can see a split into intraoperative, in recovery, and then post-operative. Just to highlight that if you do have a need to stop the infusion, that doesn't necessarily mean you need to unblind the participant, which I will come on to in the next slide. But yeah, just to say, keep this with the participant at all times. So whoever's near sort of has got that as a reference safety point. So the lidocaine infusion surveillance tool, Mark has touched on this briefly earlier, but this is sort of intended as a rapid aid to identify any clinical signs or symptoms that may indicate the patient's starting to develop lidocaine toxicity. So there's 5 symptom questions and 7 clinical signs. You should start completing the tool in recovery within 15 minutes of the participant's arrival or when they are awake enough to have a conversation with you. So you're just doing day cases. So for day cases, you ask the 5 questions. So once they're awake enough to talk to you, and then again once when they meet the criteria for discharge or step down to reduce monitoring. Sorry, that's discharge from recovery or step down to reduce monitoring. So if at any time the participant answers yes to 2 or more of the symptom questions, or they have any sign or complication, you must stop the infusion. After the infusion's been stopped, if the patient's otherwise well, stable vital signs, you should repeat the list tool hourly until all the symptoms and signs have resolved, or 2 hours have passed. So whichever happens first. If the patient is unstable, at this point you should initiate rapid or urgent review by, I don't know how it works at your site, but either the sort of anaesthetist, the theatre emergency team, or critical care team. Inform that person that the patient is taking part in LOLIPOP and there is a possibility of lidocaine toxicity. So if after that review that it's suspected severe lidocaine toxicity, you should follow the AAGB guidelines and unblind the participant. If intralipid is needed, for example, the patient's in circulatory arrest, just to highlight, don't wait until you've unblinded, start giving that intralipid. If you unblind and they are on the placebo, you can then just stop giving that intralipid. So yeah, so only sort of unblind the participant if they're unstable following stopping the infusion. If you stop the infusion and they sort of are stable, you don't need to unblind. And then all suspected lidocaine toxicity events are recorded on our form, CRF form 13. And these will need to be reported to the UK sponsor at your earliest opportunity and definitely within 24 hours. And you do this by entering the suspected lidocaine toxicity form onto the LOLIPOP database. Or if in the interest of time it's easier to email us, please email us and then you can update the database when you get a chance. So is there any questions on using the list tool at all? Nope. I shall move on. So unblinding, so yeah, briefly touched on that just now, but sort of events that mean unblinding are required is sudden unexplained loss of consciousness, tonic-clonic seizure, life-threatening arrhythmia, or cardiovascular collapse. So everyone who has access to the database will be able to unblind through their login, but also there is a sort of generic unblinding login for all sites that allow anybody to unblind a participant. So it's usually the lead research nurse will get 2 emails when you're activated. So one to activate your personal account, and then a second to activate your site's generic unblinding login. So you'll be provided with the username. You just need to create a password for that username, and just to remember to keep that generic password, obviously generic. Don't use one of your personal passwords, because that is going to be written on a piece of paper for anyone to sort of use and have access to. So again, we'll be providing you with a printed copy of the unblinding guideline that you can see on the screen here. The quickest way to unblind a participant is to scan that QR code. It will take you directly to the unblinding login. You can use the generic username and password, login, find the participant and unblind them. Just because you've got a login, you don't have to use your login. You can, like, the quickest way is to use that generic one. So, you know, whatever works for you, but don't feel like you have to use your account just because you've got one. And then, yeah, after randomization, you have the ability to unblind a participant for 36 hours. So it's important that if the participant's surgery date changes, that you also remember to update that surgery date within the database to allow that 36-hour period to be moved to the new surgery date. And then, yeah, if you do end up unblinding, there's a CRF form 11 that must be completed. And then also the suspected lidocaine toxicity form 13 will also need to be completed. And obviously we have manuals and documents that help you to know which forms to complete, or obviously you can always drop us an email or give us a call. So, you know, don't worry about trying to remember all this from today. So is there any questions on unblinding at all from today or the videos you've watched? Nope. Move on. And this slide just highlights some safety endpoints in the trial. So there's a bit of overlap with that table I just went over a few slides ago. So these safety endpoints are listed in the protocol as well. And yeah, they cross over with that stopping criteria table. So if any of these events arouse cause for concern or can't be resolved following treatment, you should stop the infusion. There's some exceptions on the list, but most of these will be kind of considered as expected events, so they won't need expedited reporting. They would just be recorded within the CRFs. So yeah, that's to say on that one, I think. Protocol breaches. So we have a protocol breach form. So in the CRF pack, form 10 records protocol breaches. So these should be completed and entered into the LOLIPOP database. Unfortunately, in the UK, there's also a protocol deviation assessment and report form that's separate to the CRF pack. That also needs to be completed, so that's a UK sponsor requirement. So you also need to complete that form and email it to the LOLIPOP trial mailbox and also the sponsor's safety email that you can see on screen there. But if you do just complete the CRF form and we see it's been entered on the database because we get notified and we haven't got that sponsor form, we'll chase you up anyway. So don't worry if you do forget to fill that one in. We'll be on your toes to get that one. And in the protocol, the Australian team have split protocol breaches examples into sort of infusion related and non-infusion related. So yeah, I won't run through them, but you can see on there some examples are like if the infusion has been stopped too early, drug dosing's incorrect. One thing I will highlight is if open label administration of lidocaine is given in excess of the permitted amounts, if this is sort of highlighted or realized before the LOLIPOP infusion has started, please don't start the infusion. If it's spotted after the LOLIPOP infusion has begun, then please stop the infusion at that point, because obviously we don't know how much which infusion they're having. If they're having the lidocaine one, they could end up having too much and leading to toxicity. But yeah, basically in the UK, any deviation from the protocol is a protocol breach. Yeah, a summary on safety reporting. So again, give me a shout if nothing's clear from the training videos, but as they go into quite a lot of detail, we haven't, we're just touching upon what you should do in each event. So yeah, you can see in the table that we just outline the different forms that need to be completed. Obviously, any SAEs, SARs, SUSARs, or significant safety issues or suspected severe lidocaine toxicity must be reported to us within 24 hours. So please enter those forms onto the database within 24 hours of you becoming aware of the event or the event happening. Is there any questions on safety reporting at all? Nope. I think I've got one more slide. Yep. So as we've started going through the trial and started data collection, and we've got participants in the trial, it's been highlighted that there is a difference in dexamethasone use between the UK and Australia. So on the CRF form, so data point 2.3.18, we are basically asking UK sites to record the dexamethasone amount according to Australian practice. So we've basically, the team have realised that dexamethasone sodium phosphate is used in the UK, but dexamethasone phosphate is used in Australia. So basically, if 3.3 milligrams of sodium phosphate is used in the UK, then you document this as 4 milligrams of phosphate. If 6.6 of the sodium phosphate is used, then it's documented as 8 milligrams of the phosphate. Again, if you don't remember that, so this is all in sort of the manuals and there's instructions on doing this, but if you do forget, it will come up as a data query for you on the database, so you will be nudged to correct that. So I'm going to hand over to Leah now, I think, to run through the final few slides.
Thank you. So just to summarise the follow-up in Lollipop, there's 3 time points, 3 months, 6 months and 12 months, with the primary outcome being collected at 12 months. The follow-up data is collected on 2 databases, so there's just like a couple of things to remember around that in terms of like which data you enter onto which. So on the main trial database, which is where the bulk of the CRF data collection is done, you'll collect a little bit of data from the medical notes. And then on the REDCap database, that's where we're collecting all the patient-reported questionnaires. So you can see we've sort of listed the different questionnaires on the screen there, along with like the CRF sections. Again, like you might come to complete these follow-ups and you might be a little bit unsure about which data goes where. I definitely recommend, like for the first few patients, having that CRF manual sort of in front of you, and kind of using that to help you like go through the data collection, just because we don't need you to enter like the patient-reported questionnaires onto the main trial database, because we don't need like double data entry. So I wouldn't want you to sort of waste your time basically entering those onto the other database when you don't need to. And yeah, if you use that CRF manual, hopefully it sort of outlines which data goes where basically. Just another thing to note, if the 3 or 6 month follow-ups are missed for whatever reason, the patient's missed them, we would still like you to try to collect that 1 year follow-up, just because it is really important, because it's our primary outcome. And we just ask that if I think, Mark mentioned at the start that the questionnaires are being collected on this REDCap database, which means it sort of like emails the patient and prompts them to do those with the links and everything. But if they're not responding to that, then we do ask you to give them a call to see if you can get them to complete that data. You can either do that over the phone with them or just sort of give them a reminder really to log on and complete those. Are there any questions about the follow-up? We'll move on then, thank you. So just following on from that, During the 3 and 12-month follow-up questionnaires, participants are asked to calculate the sort of daily dose of pain relief medication that they're taking. We sort of recognise that might be a bit tricky for some people to do, so we've to support this, we've written a guidance document that will help sort of explain how to do that for them. So most patients will complete their questionnaires via the REDCap links, and in this case, this document's sort of linked within the questionnaire itself, so it's really easy. They're completing the questionnaire and they'll get like a link that says, you know, click here for like guidance on how to calculate this, and they can just find that there. But obviously some participants might request specifically to not do their questionnaires online for whatever reason. And in this case, you'll be sort of completing those for the participant over the phone. And in this case, we just ask you to either post or email out a copy of this document to the participant, just like in advance of their questionnaire, so they've got that in front of them. Yeah, just a quick thing to note that I probably should have said in the last slide, actually. Before the emails go out to patients to ask them to complete their questionnaires, or before you get an email to remind you to complete them over the phone, you'll just be asked to check, do a mortality check for the patient, just to make sure that we're still okay to send those out. So yeah, if you're sending out this document, you do it after the mortality check, but before the questionnaire is done. That okay? Thank you. Okay, so we've just got a few more like scenario questions to run through with you. So again, not to catch you out, and if you're not sure, just let us know and we can talk through them. So what would you do in a situation where participants been randomized and then their surgery had to be postponed after that?
I think, if I'm honest, I'd probably be contacting you guys to ask what we should do.
That's fine. Yeah, so basically
a
couple. Sorry.
So I had a question about this actually, because I think it was in one of the videos. You sort of put in a new date, but if someone was cancelled, we wouldn't necessarily know a new date. So I wondered how would the database work okay with that?
Yeah, so I think it would just be a case of updating that date when you have it. The main reason for updating the date is because the database only allows you to unblind, I think, up to maybe 48 hours after the surgery date. So you just need to ensure that's updated so that on the actual day of surgery, they would be able to be unblinded if required. I think another thing to note on that is if it was a long postponement, there may be a requirement to redo the preoperative data collection. Is it a month, Chloe?
Yeah, so basically we say to draw up the vial into the syringe at sort of the very last moment when you know the surgery is definitely going ahead. Because if the participant's been randomized and the vial is unopened, you can basically put that vial back in the box, and when the patient's then rescheduled for their surgery, you find that same allocated vial, and the database won't allocate it to anyone else. If you have drawn up the vial, then unfortunately the patient wouldn't be able to go ahead with the infusion because you can't then re-randomize the participant. So yeah, so that sort of just highlighting the importance of drawing it up as late as you can, really, when you know the surgery is definitely going ahead. And yeah, then as Leah said, if the surgery is more than 30 days from their last date, then we would ask you to sort of check in that the patient's still okay and happy to be in the trial, and then repeat their pre-op data collection as well, just to check nothing's changed between those two dates.
Great, thank you. So the next question is just about what the safety procedure would be if a participant had a seizure in the recovery area.
I think we'd stop the infusion, treat them according to AGBI guidelines, and unblind them, actually.
Yeah, great. And then obviously all the paperwork that's associated with the unblinding, so unblinding form, suspected lidocaine toxicity form as well. Okay, and slightly unlikely scenario, but what would you do if the pump failed during the bolus infusion?
That's a good question. I probably just that would be the end of the bolus and then transfer to the background infusion, but I'd have to check that on the video vaguely.
No, that's correct, yeah.
Okay.
And then would that also be like a protocol breach, Chloe?
Yes.
Yeah.
Sorry. Yeah.
So just completing the paperwork for that, really, yeah.
Just to come in on that and just say, if it's something that's very, if it pauses, for example, if you get an occlusion alarm and it's very easy to sort it out, you know, kinked giving set or just needs a flush, then that's fine. You can restart. We're really just sort of trying to cover the unlikely scenario that the pump just kind of totally decides to switch itself off or something. It's just a case of obviously making the point that you don't try to recreate the bolus because it could lead to too high a bolus. But yeah, you can just default back to the, you can set it up then as a mils per hour thing and just call it quits with the bolus and just go on to mils per hour rate.
Lovely. Thanks.
Thank you. And just a last question on what your process would be if a participant wasn't responding to the 1-year follow-up questionnaire.
We would so we would be contacted by you guys because it's an electronic questionnaire, and then we would be contacting the participant, and we would usually try up to 3 times to contact that participant.
Yeah, 3 times is a good rule. Just to say, we wouldn't necessarily contact you directly, but on REDCap you have access to sort of reports, so you can monitor like the completion of the questionnaires and see quite easily who's done them and who hasn't. So that would sort of be up to you locally to manage. You know, oh, have they completed it, or do I need to sort of track them down and give them a call?
Just to add to that as well, there is a protocol amendment going through at the moment that that'll make this clearer. But basically, the Australian team are happy for that data to be collected up to 15 months. So you've kind of got a 3-month window after that, 12 months to get that data if you can.
Lovely, thank you.
Thanks. Okay, so moving on. So this is just a note about finalising your training. So now we've had the SIV today, you can go away and complete your training log. So that documents today's session and also any of the videos that you've watched. We've got this training matrix shown there, which is just a guide. You don't have to completely stick to it. It just kind of suggests what kind of modules you should be doing for your role, but it will also depend on the sort of tasks you're doing. And we do check them when you sign up to the delegation log, just to make sure like you haven't selected any tasks you're not trained to do, essentially. Yeah, so once you've done that training log, you'll also need to register on the delegation log, most likely. And there are a couple of roles that don't need to register on the delegation log, like just attending anaesthetists and things like that. But I think most of you here today will need to complete a delegation log. That's on that system there called Mango. And if you've not used Mango before, you'll just need to create an account and then you add LOLIPOP to that. But if you've already got a Mango account, which you might do if you've worked on other Bristol Trial Centre trials, you just log into your existing account and add LOLIPOP to it. Okay, any questions on that at all at the minute?
Can I just jump in, Lee, and say for the PI sign-offs on this, so basically all accounts come to us, we'll check the tasks and the training's been done correctly, and then once we set that we've checked it our side, it will ping an email over to the PI. PI can then go in and check you're happy with the tasks that someone selected. If you are, you just approve the account, and that's your sort of official signing off on the delegation log.
Okay, thanks.
Thank you. So is the next one just me? Oh no, yeah. Just a note to say that we are registered with the Associate PI scheme, and we do encourage people to register on that. I know Mark's had a really good experience at his site, so.
Yeah, we've got an interested registrar she's currently on holiday in Hong Kong, but she's sort of in the process of signing up.
Yeah, great. Thank you. Okay, so we're coming to the end now. I'm just going to share a checklist we've got, and we'll just quickly run through that to see where we're at, basically. It's just a good way to see kind of what still needs doing. Everyone can see that okay. So just to start with, obviously we've received the feasibility form from you. PI, CV and GCP certificate, so that once you sign up to Mango, you actually get the ability to upload those, so that will come through when you sign up. Protocol agreement, you'll have to remind me if we've had this from you. I
don't think we have, Leah.
Okay, so that's just the PI protocol agreement that's within the protocol. That the page is actually inside the protocol, so you should have a copy already. So if you could get that signed off and sent back to us, that would be great. The next one's about the training logs. So as we've just discussed, you'll be able to complete those after the session today. And same with the delegation log. Contract, I believe that's in progress.
Yeah, I think it's been reviewed. I think we're just checking to, yeah, waiting to go to signatures, basically.
Yeah, great. So that's in hand. Local approvals. Do we know sort of how far away we are from local R&D approval? If there's anything you need from us with that?
I think there's just a few bits that Sean needs to complete and obviously send off these documents that you require. But I'll get him to get in contact with you next week if that's okay and just update you.
Yep, sounds good. Thank you. And then ISF checklist. I believe, has Chloe sent that through already? Yeah, so that's just with you guys. Whenever that's complete, if you could just send us a copy to look at, that'd be great. I've ticked these two off because that's to do with attendance at the SIV today. Storage of study drug. We've already discussed that a bit. It sounds like you need to go away and just check if there's possibility that could be stored outside of pharmacy, but if not, that would be stored in pharmacy. Yeah. Pumps. So we usually send out the pumps once we've had the contract signed. So that hopefully will get sorted soon and we can arrange that for you. Staging database. So we've already touched on this and it sounds like a few of you might not have activated. So if you could just pop us an email if you're not able to access that staging database and you need access to it, and then we can request a new activation link for you. 50 ml syringes available for loading the pumps, so they're just the standard 50 ml syringes. Are you happy that they're available? Yeah. And then confirm that intralipids available in theatre and the recovery area.
Yep, that's right.
Providing localization details to us. I think Annie's already sent the localized documents over. So that's all sorted as well. CRF pack. Have you got a copy of the CRF pack? Do we need to share that with you?
We do, I believe.
Okay, thank you.
Thank you.
ISF setup, I get that's in progress as well. And again, pharmacy site file. So with these two, just to mention, I'm not sure if Chloe may have already said this in her email actually, but just to say that we don't mandate whether you set this up digitally or physically. It's just however you need to do this according to your local policies. We'll just ask for like a copy of your checklist and any documents we're missing, just so we can keep a kind of copy of your ISF on our side. We've already touched on raising awareness of the trial with the teams. Sounds like you're going to go away and do a bit of training with the recovery staff, so that's great. And then the last item is just about doing a little run through on the staging database of sort of patients' journey through the trial, just so you're all familiar with how that works. And yeah, we've already talked about the staging database, so that's another one that'll be in progress, I guess. Does anyone have any questions or concerns about the things on this list?
Fab, thanks, Leah. The last slide was just our contact details, so I won't bring that back up because you can refer back to that if needed. So yeah, that's all for today. Does anyone have any questions at all, or anything we didn't cover that you'd like more info on?
I just wanted to double check something, if that's okay.
Yeah.
There's no option to allocate a new kit for a patient. Is that right?
A new vial?
Yeah.
Yeah, no. Once they're randomised, there's no option.
So if there was a fault with the vial, the treatment wouldn't be able to go ahead.
Yeah, that's right. So there was basically the Australian team did before have a system where they had spare vials, and so they could you could reallocate a vial, but I think it just wasn't being utilised much, and logistically it was quite difficult to have that process in the UK, so they decided not to. It took a bit of a risk that we might miss a few patients, but from their experience of the trial in Australia so far, that risk has been so low that they were willing to sort of take that in the UK. So yeah, unfortunately it might mean we do miss a few, but hopefully will be few and far between. Any other questions? Nope. If not, just thank you all for your time today. Following the SIV, we'll send over an SIV report and outline any outstanding actions that need to be done prior to green light. And then, yeah, once they've all been completed, we can proceed to green light and getting you guys open. So thank you all again, and look forward to working with you.
Lovely.
very much.
Thanks very much.
Thank you.
Bye-bye.
Thank you.
Thanks,
everyone.
Take care.
Great weekend.
Bye.
Cheers.
Bye bye.